More than mine.
I don't know if that's a good thing.
Totally. Okay, so I'll continue to keep an eye on the waiting room. Welcome everybody to Menopause Chicks, to our first official conversation titled Hysterectomies and Pelvic Floor Surgery. I have to tell you, today I was thinking, when I started Menopause Chicks, of course, I didn't know what I didn't know, but I remember not having any personal experience with surgery, thinking that this is a very big topic. And as you were entering the waiting room for this very call today, I was looking at the names and I just, my heart is warmed by the fact that we have some new members who just joined us this week. And we have members who have been in the Menopause Chicks community. And maybe, hopefully you've followed our guest, Kim Vopni, for a while too. This is going to be, as I mentioned, the first in a series. We're really, I can't use the word excited necessarily, but we're really intent on more research, more educational content, and more opportunities for our members to speak with experts and to speak with one another about our lived experience. Because we know that with those opportunities, you can become more informed, have more informed conversations with your health team, and feel more empowered in making decisions that are aligned with your health concerns and, of course, your health goals going forward. So I'm going to try not to talk too much tonight. I just want to ask him some questions, and I'm going to get started by introducing our guest, Kim Vopni. Some of you may know her. She's the Vagina Coach. She is a pelvic floor expert and guru. She's a dear friend of mine and a huge supporter of Menopause Chicks. So I'm super grateful for that. And she has personal experience, and she's going to share her journey with us tonight, which we can all learn from, and then have the opportunity to ask questions. So just before we get started, please do find the chat. Probably along the bottom of your screen. That's where you can ask questions. I will be moderating the Q&A as we go. And if you can't stay for our whole time together, everyone who's registered, and we had, I think, over 130 registrants, Kim.
Wow.
Everyone who registered will be getting a copy of the replay tomorrow. And yeah, let's get started. So Kim, how did you get here? Tell us your story.
I don't know. It was accidentally on purpose, I always say. And really, it started way back in the day because I was afraid of childbirth. And I grew up thinking I was never going to have children. But I had been curious and had asked my mom along the way, my mom being an OR nurse who was very open with information, planted seeds, allowed me to ask questions, told me proper anatomical terms. And when I did get older and met my husband, my now husband, decided I did want to start a family, I was really determined to have a different story than my mom. So really where I started was like, I'm never having children because it ruins the body and I don't want to have anything to do with that, to making a decision like, okay, I do want to do this. What can I do to prevent it? Doing everything I knew at the time that would help me, still ending up with some pelvic floor challenges, turning that into a business, helping coach women, trying to increase the awareness about this conversation, because I really recognized that there's such a missed opportunity in many aspects of many stages of a life of a woman where we could be having this conversation. And then a year and a half ago, choosing to have pelvic surgery myself. And so along the way, I had been obviously, and still do, try to help people not have to have surgery. But when I had one struggle that I dealt with for a number of years. And in the end, after trying absolutely everything, I looked at surgery as an option. And in that process, felt shame, felt embarrassment, did not want to tell my community. I was afraid. I went through all the emotions that I know that everybody else goes. However, I felt grateful because I was very informed. I am very informed. This is the world that I work in. So I knew what questions to ask. I knew how to prepare. I knew how to recover. And in that in going through that, recognizing as soon as I shared my story, actually people flocked to me because they're like, I've been considering surgery and didn't want to tell anybody because I've been embarrassed, or I've been ashamed, or I had surgery and haven't told anybody, or I had surgery and nobody told me what you did. And, so in that process, recognize that we need to have this conversation. And there are 600,000 hysterectomies, which is a form of pelvic surgery performed in the United States every single year, just the United States. So worldwide, this is a hugely common surgery that I think people don't have all of the information about. And there's many reasons why people will have a hysterectomy and other types of pelvic surgeries. So I've been doing this since, I gave birth in 2004 for the first time. I started selling a biofeedback device that I had used in my pregnancies. That's what kind of turned this into a business. So I've been preaching this stuff a long time and I never get tired of it. I could talk all day about it.
It's amazing. And I'm going to pick up on some of the words that you used. We'll get into we should address definitions before we get too deep into it. But you mentioned fear and you mentioned shame. And I would say that when I heard that you were opting for surgery, I felt surprise and then interested and curious. And I have to say, even a sense of relief. Not for myself personally, because I'm not making that decision right now with my own health, but for the thousands of women in the Menopause Chicks community, I felt a sense of relief because I thought, oh, now there is this information about not all the technicalities per se, which is really important, but how to make the decision-making process, the questions to ask either externally or ask ourselves, is this something that I want? All of that, it all added up to a huge sense of relief. So I want to thank you for doing that, because I know, you were vulnerable in sharing your story and your own decision-making process, but that's how we learn. And we're really grateful for that.
I want to say one thing before you go on. Your response when I told you that I was having surgery was, it warms my heart, because it says, you sound, I don't remember the exact wording, but you basically said, it sounds like a confident woman has done the research and is making an informed choice about her body at this given time. It was something along those lines. And I just,
wow, I must have been on that day. That sounds amazing.
Yeah, it was. I will go back in my text and I'll screenshot it, because
oh my gosh.
it made me also,
wow.
It kind of settled me as well, right? Like I just said, yeah, you know what? You're right. I feel confident in this. I feel very informed. I know this is the best decision for me, and now I'm ready to share it. And so it really kind of gave me some comfort. So thank you.
Wow. Well, I love the word confident. So that's amazing. Okay, before we get too deep, let's address some definitions. I know from the conversations in the Menopause Chicks community that the word hysterectomy can sometimes be used as an umbrella term, and we don't often know exactly what that is. And then there are various forms of pelvic floor surgery, and we're talking about both tonight. We're also talking with an audience who might be curious, considering, scheduled for surgery, recently recovering from surgery, or perhaps had surgery a long time ago and really want to know how to plan for the rest of their healthy years. So are you able to take it away from there?
Yeah. So I guess, yes, you're right. So hysterectomy is in general terms, removing the uterus. So the uterus is removed from the body, and there's different ways that, first of all, there's different approaches to how that uterus can be removed. And then there's different, is it the uterus and the cervix? Is it the uterus preserving the cervix? Is it the uterus, the cervix, the fallopian tubes, the everything? So I think the base, so a hysterectomy essentially means removal of the uterus. Total hysterectomy would be where the uterus and the cervix are removed together. A partial hysterectomy would be where the uterus is taken, the cervix is left. A radical hysterectomy would be where everything is taken, and that is most commonly associated with people who are undergoing the procedure for cancer. And then there's different reasons for surgery for hysterectomy or other types of pelvic surgeries. So we just mentioned cancer being one. Prolapse, so pelvic organ prolapse may be another reason why somebody is having a hysterectomy. So in that case, most commonly it would be that they have a uterine prolapse. However, there are some people who may have, say, a bladder prolapse, which is the most symptomatic for them, and they have a little bit of a hysterectomy. And the doctor may say, well, while we're in there, we might as well just take your uterus out if you're done having kids. So it can happen kind of in conjunction with other things as well. So prolapse is where the bladder, the uterus, and or the rectum, those are the three most common organs, shift out of their proper anatomical position and bulge into, or in the case of the uterus, descend into the vagina and create bulges, creates discomfort. Discomfort in many types of ways can create sort of heaviness, draggy sensations. And that may be a reason why somebody undergoes pelvic surgery. Another form of pelvic surgery could be incontinence. So incontinence is where urine is coming out of our body, or gas or stool in the case of anal incontinence. So urinary incontinence, where stress incontinence is that there's little bits of urine leaking out with some sort of exertion. Urge incontinence, which is where we have very strong sudden urges that sometimes we have a complete release of the bladder. Anal incontinence, where gas or stool will leak out of the body. You can have mixed incontinence, which could be a combination of either of those. And a little mention there is sometimes prolapse can mask hysterectomy. Can mask prolapse. And so when people are offered a hysterectomy and when they're determining what is the best type of hysterectomy to have, a lot of surgeons talk about trying to do some evaluation to see if there is a hidden incontinence there that might be unveiled after they have a hysterectomy or other type of pelvic surgery, because either they would want to address it at the same time, or, can we do other conservative approaches that would help that incontinence after we have performed this other type of surgery. So those would be the most, and then surgery for prolapse. There's bladder, uterus, rectum, as I talked about, different approaches. And then there's also types of incontinence surgery that are usually involve mesh slings. Yeah. So those are the most common types.
Wow. Okay, so we kind of jumped to the end. Maybe we should take like an example of someone. One of the most common experiences that come up, particularly for women in perimenopause, is heavy bleeding.
Yeah.
Right. 70% of gynecological visits in North America are due to heavy bleeding. And walk us through what a journey might be like for someone. And I'm guessing there's maybe a couple forks in the road too for decision making.
Yeah. So I will tell you my personal story with
Sure.
heavy bleeding. And this is something that I hear about a lot through working with people as well. And mine started in kind of late 30s, early 40s. I started to have very painful, very heavy periods. They were lasting a little bit longer. After a few years, they started to become, I used to get very big clots, like clots the size of my hand would come out. So at the time, I'd never heard of the term perimenopause. I'd heard of the term menopause, but it wasn't even in my brain. And so when I look back, a lot of the challenges or issues or symptoms or feelings that I was having, I could attribute partially to perimenopause. Also through my journey, I ended up having some autoimmunity stuff, which was a contributing factor as well. But back to the heavy bleeding, my abdomen would be incredibly distended, very, very painful, hard, like it felt very hard to touch. I would be usually housebound for a couple of days. I would go through a super tampon and pads within 20 to 40 minutes. I couldn't go anywhere. Just because I knew something was off after a few years, went and got some hormone testing thinking my hormones were off, and yes, they were, but the most alarming thing was my iron. The doctor was kind of like, how are you even functioning? Mm-hmm. Because I was losing so much blood. So if I look back on that, and it was offered to me to have a hysterectomy, And I did some investigation, was told that I have something called adenomyosis, it's pronounced sometimes, which is similar to endometriosis. So uterine-like tissue, instead of in endometriosis, uterine-like tissue is growing elsewhere, like it is migrated elsewhere in the body. In adenomyosis, uterine-like tissue is staying contained within the muscular wall of the uterus and contributes to heavy bleeding and pain and what have you. So and a lot of people still say the only cure for adenomyosis is having a hysterectomy, which fine that you could, yes, we take the, but I was not prepared to lose my uterus. So I was going to do everything I possibly could to preserve and maintain my uterus, partially from cognitive brain health perspective, heart health perspective, and also partially for just the anatomy and support structures within the pelvis, knowing that hysterectomies can increase the chances of other types of prolapse. So had I not been informed, I would have opted for that, no question, because the thought, I'm suffering, I'm dealing with this, I can't have sex when I want, I can't exercise when I can't, all these things, I'm in pain. You can take that away and it would end right away. Sign me up. So had I not been informed, I would have absolutely opted for that. Why not? I was done having kids, didn't need it, I'm happy to stop bleeding. So I feel grateful for the knowledge that I had. However, the majority of people I speak with have never, ever been told about getting to root causes, right, about the risks and considerations of having a hysterectomy. And adenomyosis and endometriosis are two contributing factors. Fibroids is another contributing factor. And I guess my advice is for people, if that is you, to do some investigation work. So consider you have your medical team and get their opinion, and also seek out help from pelvic floor physical therapy, naturopath or functional medicine practitioner, hormone therapist, anybody who specializes specifically within women's health, womb health, and can speak to and help address some of the contributing causes or root causes for heavy bleeding. And if those all get addressed and that it still is an issue, then we look at considering the hysterectomy. That would be my ideal. Of course, again, people have their choices, but I want to give everybody all of the information so they can make a 100% informed choice.
I love that. It speaks so much to my personal health values, which I haven't had all my life, right? Like they kind of develop as we get older and go through these experiences, but nowhere along the line, and if you're listening, chime into the chat, but we're not really taught necessarily to question medical opinion, or that we're allowed to have values and to even really be curious. Like I just so want, as why I love your work, Kim, is like get curious about the root cause, get curious about whether or not you have alternatives. Know that you can be a confident health advocate for yourself, make the decision like Kim mentioned that she did, and then continue to be curious about what some of the steps that you might want to take if you do choose surgery, if you decide that that's the best option for you.
Yeah. And I think an important piece there to kind of finish give people what happened with with me is in the end, I was curious. I was reading books. I was talking to different healthcare practitioners, asking for different tests. And in the end, my hormones were definitely out of balance. And I also had the antibody markers for an autoimmune condition called Hashimoto's thyroiditis, which is essentially it presents similar to hypothyroidism and can contribute to a lot of the weird things that I was dealing with, one of which was the heavy bleeding. Obviously the hormone disruption can be that too. So there was other things, but another factor is inflammation in the body. And when you address root causes, so for me, root cause was eliminating things that were contributing to the imbalance between the ratio of my estrogen and progesterone that were contributing to high levels of inflammation in my body. And this was not an overnight process. This was a couple of years of trying things, and little bits were helping here and there as I reduced inflammation. And it got to the point where the final thing for me, so I changed my diet. I was working on stress management. I me personally, I chose to go on hormone therapy, took out caffeine, and alcohol was the biggest one for me. So every little thing was kind of helping along the way. And as soon as I 100% took out alcohol, which for anybody, my husband has never seen me drunk before in 23 years together, because I don't drink very much at all, but just 100% removing it allowed my inflammation to finally settle, and my periods within a couple of months completely normalized. And it actually was not long before that I'm now like 2 and a bit months away from my 1 year anniversary, my 1 year menopause. But that was it. The inflammation was the root cause for me. So had I not addressed it and had a hysterectomy, knowing then that hysterectomies can also influence your hormones, even if you keep your ovaries, yep, I would have been even more out of whack and still not have addressed that inflammation. So when we can address root causes and get our body in a better state, even if we choose surgery, we are going into that surgery, I think, better prepared and more in a better position to handle the trauma of a surgery. We have to look at it kind of like a bit of an assault to the body. But when we can be in a calm state, both mentally and physically, without huge levels of inflammation, I think we perform better and have better outcomes.
Absolutely. I want to go back to something that you talked about, adding to your health team, consulting with maybe a naturopath, a functional medicine doctor. You mentioned pelvic floor physiotherapist. Let's clarify for everybody the benefits of inviting a pelvic floor physio to our team.
I believe and I preach that anybody who is born with a vagina uterus should be seeing a pelvic floor physical therapist once a year. I think if we had this, pardon?
Or penis too.
Yeah, true. Yes. Yes. So men have pelvic floors as well. My area is with women, but from a young age, if we were explained why this is such a powerful, important part of the body, if we were told about all of the different things that happen through our life that could influence this part of the body and why we need to pay more attention and care for it through exercise and diet and annual checkups, I think we would avoid a lot of suffering. So pelvic health physical therapists or physiotherapists, if you live in Canada, they specialize in the muscles of the pelvic floor, and they are licensed to evaluate and treat beyond the entrance to the vagina. So yes, there is an internal evaluation and sometimes treatment. It is not the whole, you're not in there for an hour with having an internal assessment that entire time. They take a whole body approach. They look at breathing, they look at movement, they look at symptoms, they take health history questionnaire. It's very, very comprehensive. And the internal evaluation and treatment is one component that can really help address a lot of contributing issues. Now, if you're, so let's take fibroids. They can't necessarily go in and magically shrink the fibroid. However, the influence of the weight of fibroids can influence can affect how the muscles are functioning. So perhaps they can help improve the ability of the muscles to manage that strain or that load or the disruption from a fibroid, let's say. So their role is really about helping us keep that group, very important group of muscles, working as optimally as they can, so that throughout the stages of life that we go through, they are prepared to manage and adapt, recover if needed, depending on what we face in life. And so if we're considering surgery, I believe that they can play a role in our prehab. Mm-hmm. I absolutely believe that they play a role in our rehab, and then as an ongoing checkup once a year, even if we have no symptoms.
Absolutely. And can I just add to that it's never too early and it's never too late to get yourself an appointment with a pelvic floor physiotherapist. So if you're on this call and you had your hysterectomy 5 or 10 or 20 years ago, you were still going to get, as Kim mentioned, the benefit of working with somebody who understands maybe how your pelvic floor has shifted over the years, how your body has like maybe naturally or unnaturally adapted to missing parts, and help you make a plan for going forward to avoid. What are some of the things that we can avoid by working with a pelvic floor physio?
Yeah. So like a lot of the things that we might be
Right.
prescribing surgery for,
Right.
incontinence, organ prolapse, pelvic pain, like lots of things,
Yeah.
even tailbone pain, low back pain, all pain with sex. Like there's so many things that can be addressed. And if we do end up choosing pelvic surgery for whatever reason, there will be residual scar tissue, and they can also help manage scar tissue, whether it's from a surgery you had 10 years ago, perhaps it's from childbirth, whatever. Or even if it's, again, in the early stages, like a recent surgery, they can help make sure that that tissue, that scar tissue, doesn't create stickiness and interfere with the muscle function. So I cannot preach and talk, I talk ad nauseum about pelvic floor physiotherapy. I just think it's the most underused women's health resource that we have. And it really, truly can change lives. And I highly recommend, whether you have symptoms, whether you have had surgery or planning a surgery, regardless, if you have a vagina, I highly recommend that you book an appointment.
Yeah. I mean, we hear stories every single day, and there's some worst case scenarios out there. Like imagine you had a hysterectomy, which then leads to incontinence. And then your doctor says, oh no, we got to send you in for surgery again. And that surgery doesn't last forever. So then you have to have it again. Like a worst case scenario for some women is 2 or 3 times in the operating room.
There's a high recurrence rate with pelvic surgeries. And I think part of that is because pelvic floor physio and pelvic floor exercise, ongoing pelvic floor exercise, is not considered, is not offered, is not prescribed. I think it should be. Also, back to the root causes. For me, part of what I was also struggling with in conjunction with that heavy bleeding was constipation. Had I had surgery and not addressed constipation, I would absolutely have been, I would have had something else to deal with, or would have had to have that surgery over again. So again, we need to look at this. We need to look at a whole bunch of factors and address conservative approaches, address root causes. Then if we pursue surgery, have the healthcare team in place. And after we have surgery, it doesn't, like, symptoms will be eliminated for a lot of people, which is fantastic. And symptoms can be great reminders to do pelvic floor exercise. And when those reminders aren't there, then we're like, well, it's fine, I don't need to do pelvic. I argue we need to do pelvic floor physiotherapy and pelvic floor exercise more after we have had surgery.
Right. That's a great reminder. I mean, constipation is something that's so common with women, and it's something that we think that we should be able to, should, in quotation marks, be able to handle on our own. And by putting that on the back burner, we're potentially missing an opportunity to treat, prevent, whatever.
And sometimes constipation can be a pelvic floor muscle problem, right? So another reason why we can see a pelvic floor physical therapist, they could potentially help, if it's a muscle related issue, can help alleviate constipation. If we've tried all the water and all the supplements and the diet and all that kind of stuff and nothing's working, check in with the pelvic floor physio.
I just want to jump in here because I think it's a good segue and reminder to all of us. We can sometimes forget this, or maybe it's never occurred to us before, and that's okay too, is that it's really important to know what tools your health practitioner has in his or her toolkit. Right. So we preach, the benefits of pelvic floor physio, and there are so many, but they are not going to be able to prescribe hormone therapy. They're not going to be able to perform surgery, where your physician can do both of those things. But I find as we, navigate our way, and now as I'm, teaching my children how to navigate the health system and find their values, we're just not always that aware of, there are other things I could be doing outside of their toolkit.
Right. Yeah.
Right.
1,000%. And I think one thing that I think has been a positive from COVID is the world became aware of Google to who could help me. Practitioners went online. So we saw that health care can happen virtually if needed, telehealth. People became a lot more aware of the need for preventive health as opposed to reactionary. So there's, I think, some benefits that have come out of that. And at least what I have heard from people is, they spent a lot of time on Zoom. There was a lot of online summits. They were paying more attention to social media. So they became aware of all these options that they had never even heard of before. And one thing that I hope will also continue to happen, it has started, is collaboration between the different care providers. So recognizing that, a doctor, when they can refer on to pelvic floor physical therapy, and when physical therapists can refer on, or doctors or whoever, but all of these have other, not just tools in their toolbox, but practitioners in their Rolodex, if we still can use the term Rolodex, who they can refer on to. So that's why I love multidisciplinary clinics and that whole collaborative approach, because really it's just a family doctor is not going to cut it, in my opinion. We need several people to address. And it's not that we have to see all of them all the time, but at least investigate options and then find, it's kind of that process of becoming informed, find what's working for you and then focus on that.
Yep. And not to belabor it, but you are at the center of that wheel of your health team. So you get to decide when you have surgery. You're not told, right? You're the decision maker. And that's just a little bit of a paradigm shift, I think, for us too. But before we go any further, Kim, tell us about the work that you do, because you're an important spoke on the wheel as well.
Yeah. So what I do, I work, I would say, in collaboration with as many healthcare practitioners that will support me, but I do work a lot in conjunction with pelvic floor physical therapists. So they do the internal evaluation and treatment. They will sometimes prescribe movement and practices for people to do at home. And then I help those people incorporate their pelvic floor exercise into whole body movement, so people can exercise in ways that can help improve prolapse or incontinence, back pain, all those things that they might be struggling with. And I do that through online coaching, or I have online programs. I have an app as well. But then from the surgery perspective, I also created a program there because, again, going through that process, I recognize that there is a whole other need for conversation and education and awareness for people that are going through that process. So that's, again, I can do online coaching through that, or it's through a program.
That's amazing. We hear from so many members and stories every day of, why wasn't I told this? I wasn't aware that that was an option, full hysterectomies and no conversation about, aftercare. My doctor told me just to wait and see. Those types of things that really add to the growing frustration that we have working in the women's health space, but that individuals have, because that's taking away the empowerment and the decision-making, in my opinion. Yeah.
And I am in a lot of different, Facebook groups, private groups about prolapse and about surgery and all sorts of things. And one of the most common things is the guidelines for recovery. And so people unsure of, is this sensation normal, or what is too heavy? When they say don't lift anything too heavy, what does too heavy mean? And then they say, okay, well then what about return to fitness? And so the guidelines are quite vague. Don't lift anything, gentle walks only. And then after 6 weeks, you're good to go. And it's sort of like a postpartum recovery, where I think the postpartum 6-week green light is, I think we need a lot more than that. I think it would be irresponsible to send somebody back to normal at 6 weeks postpartum. And I think it's also irresponsible at 6 weeks post-op to send somebody back to normal. So we need some guidelines provided. And this is what I was attempting to do in my program, guidelines around those early days, the early weeks. When do you start pelvic floor exercise? Should I start pelvic floor exercise? What can I do from a food and nutrition perspective? What does rest look like? When I'm walking, what should I be paying attention to? What does it look like if I'm, lying down on the couch? What position should I be in? Or What is too heavy, and what is a lifting strategy if I have to lift something? How do you build your support team to kind of like after you've had a baby, ideally having family members and people who can come and cook foods for you, who can do the lifting for you, who can do the laundry, and then return to fitness. So at 6 weeks, a lot of people get that 6-week green light, and then they're like, great, I have no more symptoms. I said I'm healed, and I'm going to go back to running like I did before. And I'm going to go back to heavy weightlifting. And those are all possible. Absolutely. However, the core, the pelvic floor needs to be retrained. We have to go through a gradual progressive loading of those tissues again to build up strength and resiliency, especially in the presence of now some change in the anatomy, some scar tissue. And knowing that, so in a hysterectomy case, the recurrence rate, the rate of prolapse after hysterectomy can be upwards of 43%, higher in people who have had a hysterectomy because of prolapse. And so many people go through the process not knowing that. And then some of the activities that they may have been doing, or constipation or something, could have contributed to the development of that prolapse that they had a hysterectomy for. So if not addressed, again, we need to provide more information. We need to give more guidelines to people. Yeah. And in my opinion, from a management perspective, pelvic floor physio is mandatory, pelvic floor exercise, and the hypopressive method. This is something that I think plays a huge role, especially in people who've had hysterectomy, can help reduce and mitigate that increased risk of subsequent prolapse after a hysterectomy.
Yeah. Oh, good points. Right. I did share yesterday on social media. I found my mom's medical records, and I don't even think she was aware that she had a vaginal hysterectomy.
Yeah.
Like,
crazy.
I'd like to think we've come a long way, but I'm still shocked and surprised by a lot of the stories that we continue to hear. And it goes back to that wheel too. Like, surgeons are amazing, right? They're so trained, they do excellent surgery, but then maybe by the time that surgery fails or needs to be redone, like, that surgeon isn't on your repertoire, right? So it is your family doctor being proactive and having those types of conversations with you. There's a big gap.
Yep, totally. Yeah, so it comes back down to the information, the collaboration between healthcare. So one of my favorite surgeons, Dr. Darren Lazar, he's in Vancouver here. He has a pelvic floor physical therapist in his office. He is always prescribing. He's always offering that as your first, so trying all of those. Here's your first line of defense options first. And then if we do surgery, here's what I would do. And here's who you're going to be working with and what you'll be doing to maintain that afterwards, which that should be the normal standard of care, in my opinion.
That's so positive and encouraging. Awesome. Okay, we're going to get to some questions. Kim and I may or may not be able to address specifically, but we want to do our best to support your decision-making process, or maybe steer you to where you need to go. So a couple people sharing hysterectomy for fibroids. When that caught my eye, and I just thought I'd throw this in there, that I have heard of a lot of members who have had a hysterectomy for fibroids. It's not always necessary. It could be your choice, but the root cause of fibroids is progesterone imbalance. And so that might be a conversation that you want to have either with your primary care physician or a naturopath or hormone balance expert. Is a hysterectomy what is done for endometriosis?
Endometriosis is so hysterectomy can be helpful for some people with endometriosis. It is not a cure for endometriosis. It's often offered. I know from a personal perspective, I know a handful of friends who have dealt with endometriosis. A couple of them have had a hysterectomy. A couple have experienced significant relief, and others have experienced not much change. So that's a conversation for, again, you and your practitioner, but also ideally with a few different practitioners to look at what else could we be doing to help manage that. So it could be offered, but it's not going to be a cure.
Right. Okay. 55 and scheduled for surgery due to fibroids. Currently on hormone therapy. Should I keep my ovaries?
So more and more research is coming out looking at the relationship between dementia, Alzheimer's, sort of cognitive impairment, and hysterectomy, but also oophorectomy, which is the removal of the ovaries. And you can have one or both removed. And the research is showing that especially the risk increases. So the risk for Alzheimer's and cognitive decline increases in people who are younger. So kind of basically before menopause, usually younger than 45 years of age. So somebody who's 55, I'm not going to assume, but the average age of menopause, so no more periods, is generally around 51 and a half-ish. So potentially this person is no longer bleeding. So the risk from a cognitive would not be as high or as significant because they've passed that, they're higher than the age of 45. So I personally would still keep my ovaries if I could, if there's no reason to take them out. So some people will argue, well, what about ovarian cancers and that? So we look at what's the person's risk of those, and then you make your decision at that point. So I'm not going to tell you whether you should keep your ovaries or not, but I would do some research with regards to Alzheimer's, cognition, with regards to hysterectomy and unilateral or bilateral oophorectomy. So that's taking the ovaries out. And if you're on HRT, so I'd be curious as to what kind of practitioner you are working with. And also, what else have you done to address the fibroids? So have you looked at diet and nutrition and lifestyle management that could potentially help with that? And are you symptomatic? So some people have fibroids and they're not symptomatic, and they might still be offered a hysterectomy. So are you symptomatic? What are you dealing with? What's the rationale behind even having a hysterectomy in the first place? So part of the decision-making with surgery, in my opinion, is having all the information, checking out root causes, going through first line of defense things, and coming down to a point of, we've tried everything, and now are these symptoms interfering with the quality of my life to such a degree that the risks that may be presented with surgery, I'm prepared to take. So that was a long answer to that question. I'm not going to answer if you should keep your ovaries or not, but you are past what would be considered higher risk age of people having their ovaries removed and having a higher rate of Alzheimer's and dementia.
Well said. And I will speak to sort of what I hear from most healthcare professionals. Keep your ovaries if you can. If you have cancer, that's a different story. But I think there's some outdated thinking from some practitioners who approach the hysterectomy and say, well, we're in there anyway, we may as well, if you're done having children or you're past menopause, take the ovaries too. That is old, outdated thinking. Yeah. So if you can keep your ovaries, keep them. And hopefully that answered your question. Yeah. Totally agree with Kim. Had my first pelvic floor physio appointment on Monday. Okay, next one is, it seems that Canadian physicians have not been taught to read hormone levels. That's true. How to ask this test to your physician, and do you know who can read this test? Yeah, so that's a little bit, I'm doing actually, is it Maeve? I'm doing a masterclass on Friday, and I've added a section to it on all questions around hormone therapy and testing. So if you want to join me for that, I'd love to see you there. But the bottom line is that most family physicians, well, all family physicians don't receive hormone health training in medical school outside of the 1 hour that they talk about menopause. But that doesn't mean that there aren't health professionals and practitioners trained in women's hormone health. So that's who I would recommend to send you to. And then just a short little snippet on testing. Testing your hormone levels is not always necessary if you're working with a hormone expert, especially if you're in perimenopause, for example. It's not even going to always be beneficial, but testing can confirm or deny a hypothesis. And it can also uncover things that don't often come up in our conversations with our health professional.
Yeah. Can I just add one
please.
thing there? So my personal experience, so if I look back to, 12-ish years ago, when I started feeling these weird symptoms and in my head thinking it's got to be hormones, started to read hormone books, went to my doctor at the time. I was starting to use naturopathic doctors, but still went to my family doctor, asked to be tested for my hormones. Everything came back as normal. And then that was the one where there was like, but your ferritin levels are really, really low. So I took that and said, okay, I in my gut, I knew that my hormones were not okay. And that's when I started to transition, and I was only working with, at the time I was working with a naturopathic doctor who different testing revealed a different picture with regards to hormones. So if you can, in my opinion, this person's in Canada who's posed this question, you can ask for some testing through your medical provider. However, a lot of times it will be denied. So, and it's not always the doctor who will deny it. They will deny it because they say this request will get denied because we don't have something they don't support preventive medicine. They need to have a reason why I need to check this. So it's not always the physician who's not allowing it. It's that knowing that their request won't get allowed. And the ranges that they consider normal are much bigger, and I wouldn't consider it to be optimal. So they consider a sicker population in that range. And so we want to be looking at practitioners who use different ranges, more optimal ranges for looking at hormones. And then there's different types of hormone testing. And as Julie, just called you Julia. Sorry, I was talking about my business partner, as Shirley just said, testing hormones is one time. Hormones are constantly fluctuating. So you can test for them, but it's exactly a snapshot of if you don't always get the clearest understanding. I like the Dutch test for some people, but that's something to talk about with your care provider.
And you've mentioned endometriosis, Maeve. So if you need help in a referral, just message me and I can support you in that. Carmen says, had my first one about a year ago. I know she's referring to a pelvic floor physio appointment because we go to the same clinic. Had my first one about a year or so ago due to this group, was super helpful, was intended due to occasional stress incontinence, but bonus was that it helped with lower back pain. I had no idea.
95.3, I believe, is the result of one study. 95.3% of women with lower back pain will have some form of pelvic floor dysfunction. The correlation is huge. So that was one Canadian study done by Dr. Sinead Dufour, who's a pelvic health physio in Ontario. And and I hear all the time people who come into my programs for prolapse, and prolapse also can create back pain as well, but incontinence, who go through and they're trying to address that issue and they end up not having the back pain anymore. So so I love that you've found relief for both of them.
Yeah, me too. Oh, the next question, I'm glad you brought this up, Megan, is about ablation. So question about recovery. I'm having one next week. What should I expect?
So ablation is essentially going in and it's kind of like burning the lining inside that can be indicated for some people who are dealing with heavy bleeding. So it can be offered as a potential help for that. And for some people, it can be life-changing and help. And for other people, it makes no difference. If you're considering ablation, you want to make sure that there's been a lot of investigation to confirm that there's no risk or any presentation of any cancer, because it could potentially increase that and make it more pronounced, I guess is the word I'm looking for. So recovery after that will be less than if you have had a hysterectomy or other things. However, it's important to rest. So you're saying you're doing
next
in
week.
So
1 week.
In preparation for that, I would take out alcohol. I would take out caffeine. I would really get your diet in check. So trying again to be reducing inflammation. So keep your diet really nice and clean and nourishing, and not a lot of inflammatory foods. And then carry that on in the post-op and post ablation as well. You're going to want to rest for, I like to have time off your feet really for the first few days, a lot of rest, then gentle walks around the house. You will be back to movement a little quicker than somebody who had a full hysterectomy or had any other form of pelvic surgery, but don't underestimate just because you haven't had an incision and sutures and removal of something that you don't need to rest. And I again would also see pelvic floor physical therapy as well.
That's a great answer. And I would encourage you to have a conversation and get curious about hormone health as well, because ablation can fix the problem, which I assume is heavy bleeding, but it doesn't address a hormone imbalance if that's the root cause.
Yep.
Carmen, 51, fibroids, one fairly large. I have been given 2 options for treatment, UFE. Can you see the chat, Kim?
Yes, I can.
Okay.
Yeah.
Or mini laparoscopic hysterectomy, the removal of the uterus, tubes, and cervix. Trying to do research, finding all kinds of information, but nothing really clear on helping me decide which way to go.
So I actually don't know what UFE stands for.
Okay, I thought you were going to fill me in on that.
No,
Carmen?
I don't know what UFE is, and I'm, yeah, so I don't know what that is.
If she's still here, she'll jump in and tell us what UFE is and we can come back.
Okay. So again, I'll go back to Carmen and also say, what symptoms are you dealing with? And so what are you hoping?
Fibroid embolization.
Oh, okay. Yes. Yeah. So that's kind of like just going in and trying to cut off the
fibroids.
Yeah. So if I was looking at those 2 options, again, I would want to keep my uterus and keep all of my stuff intact if at all possible. So I would probably choose the embolism first, and not embolism, the removal of the fibroids. And yes, so that's again, but I also want to know what symptoms are you dealing with? So what are you hoping that the UFE or the laparoscopic hysterectomy would address? And then back to our root cause conversation, have you looked at diet? Have you looked at stress reduction? Have you done work with naturopaths or supplementation, hormone balancing, all that kind of stuff to see if it would reduce or eliminate the symptoms, even though you have a fibroid? So people can have fibroids without being symptomatic. Just because you have them doesn't mean you need to have them treated per se, right? It's more what sort of symptoms are you dealing with? So if Carmen wants to add that in there as well.
Yeah, and I'd be curious about progesterone therapy too.
Yeah.
Okay. Sandra, 49, have had stress incontinence for many years, 20 plus, and I think it got worse after a stroke at age 29. Have seen pelvic floor physio, GP, OB. Now it is really affecting my life in terms of exercising, which I love. Recently, a small fibroid showed on an ultrasound, have not had any real advice as per what to do. As Kim said, maybe hormonal, diet, lifestyle. Would love to have some referral resources for different opinions.
Can you read the first part? I was looking for that to read it with you and I couldn't find it. Can you just read
that? Sandra, she's 49 and she's had stress incontinence for 20 plus years. She had a stroke at 29, so 20 years ago. And she has seen a pelvic floor physio, GP, and OBGYN, I assume. And now it's really affecting her life in terms of exercising.
Yeah, got it. So seen a pelvic floor physio, which is fantastic. Have you been consistent with pelvic floor exercise? And so pelvic floor exercise, people think of Kegels, and Kegels are one form of pelvic floor exercise, and Kegels coordinated into movement can be, in my opinion, a more functional way to approach it. However, we want to understand if the muscles are potentially lacking tone, or if they are holding on to more tension, have more tone than what would be considered optimal. Because if we add Kegels to somebody who already has more tone in their pelvic floor than what would be considered optimal, then that could potentially not address the issue, but also even exacerbate something. So if you think back to when you saw the pelvic floor physical therapist, did they give you an indication of the status of your pelvic floor muscles? And were you provided some sort of protocol from a movement perspective and pelvic floor activation afterwards? And have you been consistent with that? The other thing that I would add on there is hypopressives can also help with incontinence for people who are struggling with that as well. So stress urinary incontinence generally responds best to exercise and optimizing the pelvic floor. And that might be a combination of releasing tension in and around the muscles and learning how to activate it through a full range of motion again, sometimes layering in hypopressives as well. So I would want to know what sort of pelvic health practices have they done since seeing the pelvic floor physio. So it's like, I promote seeing a pelvic floor physio. Just seeing one, that's a great first step, but you still have to do the work of moving the pelvic floor as well afterwards.
And sometimes you need to be reminded a few times, right? Kim has a really great app. Just go and download it from vaginacoach.com, because not only the quality of the exercises and the videos that are in there, it's like just having that reminder is, well, what will keep you compliant, you know? Right?
Yeah.
How many years has it been? I'm just like, oh, can I please do your challenge again? I need a do-over. I also want to give you props because you do really well with these Q&As. They're not easy questions. Most women have quite a story to tell. So thank you for taking time to do this with us. Kate says, I had a pelvic floor surgery 2 years ago, VTT, rectocele, and anterior repair. I've happily gone back to running and full activity. Question, I was told the surgery only lasted 5 years. Does my high impact activity shorten that 5-year window, and would the pelvic physio extend it? Also, I'm having pain in my tailbone. Did you say it could be related to the surgery? I never put the two together. Do you want me to break that up for you?
I got it. I was reading along with you.
Okay.
So it helps when I can see it. So yeah, so there is I think we don't, the 5 years, like how long a surgery will last, that's generally what a surgeon will tell you is roughly 5 years. And again, there's so many factors that can go into that. And I think that if we haven't addressed root causes, is that going to make it sooner? Is if they aren't compliant with exercise, is that going to make it sooner? Maybe, but there's also people that have had repairs 15, 20 years ago who haven't gone to see pelvic floor physiotherapists and who haven't done all these things. So there's so many different factors to consider. I wouldn't, don't get too hung up on the 5 years. Here's my opinion. Do what you love from a movement perspective and support it with annual pelvic floor physiotherapy check-in and pelvic floor exercise. I would also recommend hypopressives, especially because if you are a runner, I don't know how often you run and how long, but we do have some research that was comparing running with CrossFit. And in our pelvic health world, we all thought CrossFit was going to be the one that was going to be the contributor to more symptoms and more challenges, but it was actually the runners who had more kind of ongoing, especially long distance runners who experienced more incontinence and issues. And actually looking then at the CrossFit people, the heavier lifters actually had less prolapse symptoms, which I thought was really interesting as well. So we need to load the pelvic floor. We need to move in ways that benefits our heart, our bones, our brains, all that sort of thing. However, we can also, knowing that we are women who have been menstruators, many of us who have been, who've carried children, given birth vaginally, we will all go through menopause. Those place additional challenge to the pelvic floor. So we, in and amongst the physical activity that we do, can supplement it with pelvic floor physio and exercise. The tailbone pain, that can be overactivity in the pelvic floor muscles and also maybe even scar tissue related. So after we have had a surgery and we have scar tissue, it can influence the muscle function, and it could also pull. So sometimes the adhesions start to create tension that can influence some of the attachment points of the muscles as well. So pelvic floor physiotherapy 100% can help you with that. So I would take the 5 years out of your mind and just do what you love from a movement, balance out what you do with like the effort and the ease. Have some high impact and have some low impact, have some yoga, have some walking, have some running, have some resistance training, and also incorporate your pelvic floor.
Yeah, that's good. And I think it's like, you don't want to have a foregone conclusion in your head, like to make that 5 years. Like we're all so individual, but it could almost happen if you keep thinking about that, and taking care of yourself you just would totally fall outside of that circle. It's like an insurance policy for surgery. Yeah. Okay. Deborah, long history of endometriosis and related operations, menopause 4 years ago, I assume, large fibroids, which self-resolved, was painful. The OBG oncologist was amazed. Lasted 6 months, then back. I am scheduled for hysterectomy in 2 weeks. I beg to keep my cervix for sexual and help avoid prolapse. He agreed if everything looks good. I am hoping this will help.
Yeah, so it resolved once. What did you do? Are you prepared to see if it will resolve again? So what symptoms are you looking to address by having the hysterectomy? Keeping the cervix. So there is some research to support that keeping the cervix can help from a sexual response perspective and potentially reduce the rate of recurrence. And if you keep a cervix, but also if you remove the cervix, there's something called McCall's, a procedure called McCall's cultoplasty, and there's different variations of that, which is essentially suspension of. So when the cervix is removed, the vagina is still kind of hanging out there, and it needs to be, ideally, instead of just sewn up, we need to suspend it again, and that can help reduce the risk of subsequent prolapse as well. So you'd want to talk to your physician about how are they supporting the vagina after the hysterectomy, whether you have the cervix removed or not. And yes, so questions back to you is what did you do to have it resolved the first time, and maybe try that again? And what symptoms are you hoping that it would address?
Great. Do you know what urodynamic testing is? Mm-hmm. Terry saw your gynecologist 2 weeks ago, and she wants to do urodynamic testing. What can I expect from this type of test as far as discomfort?
So urodynamic testing is where they want to, so if they're doing it's exploratory, they're trying to investigate the response of the bladder usually. And so they'll fill the bladder. So you'll be hooked up to a bunch of different things, and they'll fill the bladder, and they will ask you, when do you get the first sensation to want to void? When's the next? When does it become urgent? So they're trying to look at if the responses that you're experiencing, like, so a lot of people who might be dealing with overactive bladder, is the sensation you're experiencing aligned with how full the bladder is. And so that can help rule out or confirm overactive bladder or other issues. Nobody really loves going through that. I wouldn't call it painful. It's just kind of awkward and uncomfortable.
Sounds like it, but I always learn something new. So thank you for explaining that. Here's Kathy's question. If you have no noticeable symptoms to address and you want to make an appointment with a pelvic floor physio, what kinds of questions would you ask?
Yeah, awesome. I'd love that. So even if you have no symptoms, if you have a vagina, go and just say, I'm here. I want to be proactive with my pelvic health. I would like to prevent things like incontinence and prolapse and chronic back pain. And I just want to have an understanding of the status and state of my pelvic floor. And so the pelvic floor physical therapist will look externally, again, at your posture, your breathing, your movement. They will look at the external genitalia and screen for skin conditions. So things like lichen sclerosis is quite common. They will see if there's any tender or painful spots. They will ask your health history. They'll ask from a sexual health perspective if there's any discomfort with insertive sex or can you orgasm, those types of questions. They will assess the position of the organ, so bladder, uterus, rectum. They may ask you to cough or bear down to see if there's any descent. They may assess you in standing to see if anything shifts when you're standing up. They will assess your ability to contract and relax the pelvic floor, and then from there may provide you information about exercise to focus on relaxing the pelvic floor, or to focus more on the contraction, or to focus more on the lift. So you walk away with an understanding of how to do Kegels, and also what aspect of a Kegel would be most helpful or beneficial for you. Those are the main questions that I would ask. And then you're going to rebook again a year from now.
Well said. Well said. How soon after hysterectomy can I ask for hormone replacement therapy?
Oh, that's actually a good question. I think right away, like I would talk to somebody ideally before you've had your hysterectomy. I don't think there's, I know no reason why you couldn't start right away, but I would say if you could start prior to going. So I started, I was on hormone therapy prior to my surgery. I also started local vaginal estrogen prior to my surgery to get the tissues in the best state possible prior to the surgery as well. So, if you can
have the conversation.
Yeah, have the conversation ahead of time. I'm just reading the house. Yes. So this person was talking about blood pressure and heart issues as well. So there's a lot of research and a lot of great books. Shirley is going to be doing a class. I would go to her masterclass with regards to that, because she'll be discussing all of the ins and outs about the benefits of estrogen, really, that we have had a lot of fear with regards to estrogen, and it really can provide a lot of incredible help for our brains and for our hearts and for our bones. So go get informed with Shirley's masterclass is what I would recommend on that.
Yeah, thanks. And Deborah, it's really an individualized protocol, but I remember you said you reached menopause 4 years ago. So the general guideline, not a deadline, but a guideline, is that you do start hormone therapy within 10 years of menopause, which for some is surgical or under the age of 60. Again, it's a guideline, not a deadline. Okay. Thanks for staying for a few more minutes, Kim.
Yeah, of course.
I had hysterectomy 6 years ago due to heavy bleeding, and obviously did not have all the info I needed to make a better decision. I had had 2 C-sections, but was told I could not deliver naturally due to what they call pelvic disproportion. My daughter has been told similar. She is only 24, planning to have kids in the next few years. Would pelvic floor physio help with this? As well, I have constant UTIs. Can pelvic floor physio help with this too?
Yes. Yes, and yes, and yes, and yes.
Yes.
So
yes.
I would, you and your daughter both highly recommend that you see pelvic floor physiotherapist. The pelvic disproportion, I think that again, when we have labels applied, labels can sometimes help, and they can sometimes affirm maybe what we've been feeling, but I think that they can also interfere. And this is one of the cases where I think that there can be some interfering happening. So if you from a birth professional, I'm not, I have trained as a doula, but I wouldn't call myself a birth professional, but I work with many midwives and doulas, and a lot of them will tell you that no pelvis is too small. And a lot of if we are provided the tools and the environment to allow the pelvic floor to respond appropriately, we can birth our babies vaginally. So very, very, very rarely is there a pelvis that a baby can't come through. So I would absolutely have them work with a pelvic floor physiotherapist. I would have them work with, if they decide that I think it said that she does want to have kids. So working with midwives and doulas who are very informed and talk maybe about pelvic health. And yes, so that's what I would say with regards to that. And have her see pelvic floor physiotherapist, because that can also help her from just getting to know her body prior to becoming pregnant. And then constant UTIs. So this can be, UTIs can increase as we approach and move beyond menopause. And there's many different reasons, but it can be associated with the tissue, with the pH level in the vagina. So estrogen therapy is something that potentially could help with that, keeping the vagina moisturized. The products that you might be using can also play a role in there. So pelvic health physios will not necessarily, they can't prevent a UTI. They can keep your muscles working optimally so that blood flow and circulation is working well. That could potentially help offset it in conjunction with other things that are helping support the tissue. So that's what I would say for that.
Yeah. On May 5th, Karen, I'm doing an event like this one on saying goodbye to UTIs with a urogynecologist. So you might want to jot that date down. And just a sidebar, I know your daughter's 24. My daughter's 19 this year. But last summer, thanks to Kim and the amazing community that we get to work in, my daughter hadn't yet had a visit to the gynecologist or anyone actually. And I was really afraid of what that experience was going to be like for her because I couldn't control whether or not it would be positive or negative. So what I did was I took her to a pelvic floor physio first, just so that she could have that experience, because I knew that it would be positive and informative and educational. And I know your daughter's older, but I would suggest that she does that. Well, obviously, just because Kim said to do it, so do it. But it's just it's like things will come up, you will learn so much. And then like the internal part is like 5 minutes of a whole hour appointment, and you get to ask all kinds of questions and learn so much. So
totally agree.
Total sidebar, but I wanted to add that in. Okay, is it true that hormone therapy can cause fibroids to grow?
So fibroids can be a result of many different things, hormone imbalance. So if you are working with somebody who's not educated from a replacement perspective, I guess you could argue potentially, but I wouldn't say that definitively HRT causes fibroids to grow.
In fact, it can decrease them. What are hypopressives? Haven't heard of this.
The term hypopressive means low pressure. It's also called low pressure fitness, and it is a specific exercise technique that the postures or the poses that you get into are, they don't increase intra-abdominal pressure. So intra-abdominal pressure, if you can think of this as the diaphragm and this is the pelvic floor, we have something in here called intra-abdominal pressure that is part of our core control mechanisms. We all have it. All sorts of things influence it. Increases in intra-abdominal pressure can sometimes be contributing factors to incontinence or to organ prolapse. And so learning to manage that pressure and also putting ourselves in positions where we don't have as much can help alleviate symptoms and can also potentially improve the response of the pelvic floor under load and intra-abdominal pressure. And so hypopressives are one version. I actually have a little sheet right here that shows you some of the poses. The most distinguishing factor with hypopressives is the drawing in and up of the abdominal wall. So when you look at somebody in a hypopressive apnea, so an apnea means a breath hold, it looks like they have sucked their abdomen in and flared their ribs out. And the way you get into that apnea is an involuntary response to expanding the ribs without inhaling. And that creates a sort of suction or drawing up effect that creates that looks like somebody has sucked in their abdomen. So here is a picture of, so you can kind of see here, oops, my finger. Yep. This happens to be one of the poses, but you can see that sort of drawing in and flaring of the ribs, and sort of it looks like she has sucked her abdomen in. And you can see that in this position. So these are just some of the more common positions that you would do it in. It is hands down my most favorite exercise technique. It is the only thing that I have been 100% consistent with for over 10 years now. I love it. It helped me reverse a stage 2 uterine prolapse in my own body. It's a very, very powerful technique. People who have high blood pressure, if it's managed with medication, they may be able to do it. It's also not indicated for people who are pregnant. They can go into the poses, but they wouldn't do the apnea. it has been shown, like there are people who have reversed early stage prolapse, who have improved more advanced stage prolapse, who've reduced eliminated symptoms. It helps with back pain, incontinence, prolapse, posture, nervous system, fascial regulation. I love it. It's my absolute most favorite technique.
And follow the Vagina Coach on all her social channels because she has some great videos as well. Great. Okay, we've got 2 more questions, Kim. I'll cut to the chase. Will pelvic floor physio help with the urge to pee that coffee brings on?
Not really. So urge incontinence is not something that will, I'm not going to say you won't have any improvement with pelvic floor exercise or pelvic floor physio, but it is coffee and caffeine is a bladder irritant, and it can contribute to stronger urges. Urge incontinence is not also something that can be treated surgically. So working with a physio or using a bladder diary can help identify things that could be triggers for you. So things that contribute to the bladder becoming irritated and wanting to void. Dehydration is another one. So when our urine is really concentrated, alcohol, dairy, sugar, caffeine, spicy foods, artificial sweeteners, those would be the most common irritants. Not to say that they're irritants for everybody, but if you notice by starting to record things, so you've obviously paid attention that when you drink coffee, you get stronger urges, you then make a choice. All right, if I'm drinking coffee, I know I'm going to have stronger urges, or am I going to make it decaf or half calf, or am I going to stop drinking coffee? So you can kind of choose from that point. But I would still, regardless of what your choice is with regards to coffee, see your pelvic floor physiotherapist, and that will help also optimize that group of muscles so that if you have that urge and you also need to manage, some people notice they have urge and then they have to get to the bathroom really quickly, or they might have some urine leaking out, then the pelvic floor physio and the exercise will help manage that so that you're not leaking as well as dealing with the urgency.
Amazing. Is acupuncture helpful to relax the pelvic floor and assist with pelvic floor physio?
It could. So there are some pelvic floor physios who do variations of acupuncture. Botox can even be used for the pelvic floor. Like there's all sorts of things that can be helpful and beneficial. So I wouldn't say that every single physio does acupuncture, but it is a tool that some of them have in their toolbox that could be helpful for some. In terms of a relax, so if you have an overactive pelvic floor, or you've been told your pelvic floor is too tight, or you need to work on relaxing, hypopressives actually can help regulate and down-regulate an overactive pelvic floor. Release exercises. So I have some on my YouTube channel. I've got a whole series of them in my app as well that can help release tension. Posture is also another thing that can help us manage tension, and not necessarily this posture, but the position of our pelvis. So when we're sitting, so I'm sitting right now in a chair, and I want to make sure that I'm sitting on my sit bones with my vulva on the surface of the chair, as opposed to being tucked under. That can contribute to tension in the pelvic floor and contribute to more overactivity. So posture, breath, working on the core breath, that's something on my YouTube channel as well, working with a pelvic floor physio, hypopresses, and potentially manual therapy from the physio. And then if all those other things haven't helped, then potentially acupuncture or even Botox could be helpful as well.
Very cool. Thank you so much. Time always flies whenever you join us. Before we let everyone go, walk us through how we can work with you.
So vaginacoach.com is my website, and I do have my programs listed on there. So I have online programs that are essentially, you purchase them, you access them online, you have access for life. It's a one-time payment. I also have an app there's a bunch of free content, but if you want to have access to more of like hypopressives and the other workouts and all the other stuff that I have, it's a monthly payment of $27, and you have access to everything while you pay. You can cancel at any time. I also do online coaching. So we would meet on Zoom like this, and I personalize movement and teach you hypopressives or whatever it is that you want to know, depending on what you're trying to manage. And if you're happy with free content, I post exercise videos on YouTube once a week, and you can check me out there. And social media, I'm even on TikTok now. Oh my God, I'm all the platforms, but TikTok is I resisted TikTok for so long, and now I actually am kind of getting into it. So
You're everywhere. I love your programs, but I'm glad that you mentioned the one-to-one coaching, because if you're on this call and you've been recommended to have surgery, or you're trying to decide yourself, and maybe, you know, your girlfriends are great support, but they're not always the best resources when it comes to making those types of decisions, then book a call with Kim and or you know, look at her programs and just feel confident in the decision that you're making before, during, and after.
yeah. And I would say just to the pelvic surgery program, it would be cheaper actually for you to do that rather than coaching. And like you have access to everything that's in there, but also in there is interviews with surgeons, interviews with pelvic health physios, and also interviews with people who have gone through surgeries. So there's different case studies that you can hear other people's experience. You can hear what they would have done differently, if anything. You can hear, not like when you go to the forums online, it can be a really dark place, and you hear all of the negativity and all of the horror stories. And we have to recognize that the people who have had success aren't in the forums.
That's
right. So I'm trying
That's
to highlight
really
that there's
good point.
Yeah. So it's in my opinion, it's a really good comprehensive program that will support you through the whole decision-making, preparation, recovery, and even return to exercise.
Amazing. Okay. So go to vaginacoach.com, click on programs, look at the pelvic surgery program. And thank you so much for all your questions too, and for showing up today, because I always learn whenever I have the opportunity to chat with Kim. And if you haven't already done so, the masterclass is on April 22nd, and it's a supersized version. So we're going to be doing an extra section on hormone therapy. So Kim, thank you very much. We're going to let you go. Really appreciate your education, experience, and expertise that you give to menopause chicks.
You're welcome. Thanks everybody for joining us. Thank you for asking amazing questions and for having such an incredible platform and including me in it. I really am honored. Thank you.
Okay. Good night, everybody.
Bye.